This is Krista Michener. Welcome back to Made to Be Whole. Stay tuned for part one of our two-part series with the incomparable Randy Breton, pharmacist extraordinaire from Infuserve America. Made to Be Whole is intended for informational purposes only. It's not intended to replace the advice or care of a licensed healthcare professional. Participating in this podcast does not constitute a provider-patient relationship with Krista Michener, AHP Integrative Health, or any of the guests featured on Made to Be Whole. Krista Michener, AHP Integrative Health, and any featured guests aren't responsible for any losses, damages, or liabilities that may arise from use of information obtained in this podcast or associated materials. Please consult a healthcare professional for any health-related concerns that you are experiencing.
Wow.
Okay.
Now that was an introduction. Thank you.
You're welcome. You earned it. You and Carrie are way up here on my list of peoples. So, Randy, first of all, just tell us about you, your background. How did you decide to become a pharmacist and what led you to compounding?
I'm from Maine originally, but I went to school in Massachusetts, Northeastern University specifically. When I started there, I was a very good biologist. And that was going to be my major. I quickly found out that biology wasn't going to pay the bills. So I immediately switched over to pharmacy, and come to find out a lot of the anatomy, physiology, chemistry, all the other fun stuff that I was doing in biology was transferable into that. And not only that, Northeastern, of course, is in Boston, Massachusetts, which is full of just some of the most top-notch hospitals on the planet. So a lot of my early jobs as a pharmacy technician before I was a pharmacist, specifically at the Children's Hospital in Boston, were that was one of my learning years. My stomping ground was there. And
you learned some pretty unique
yeah.
things there, it sounds like, too, just from other conversations we've had about the inhalations and other things.
Northeastern's an interesting place. It's what they call a co-op school. At least it's where you go to school for half the year, and then the other half of the year you actually get a job. So a lot of those jobs were pretty interesting. I worked for General Foods for a while as almost like an intern doing analytical chemistry, HPLC, and all kinds of other interesting chemistry type stuff. And then again, a lot of my internships in and around Boston were, like I said, at Children's Hospital, but I also had stints at the Deaconess and other places around that area. Children's was interesting because it was kind of my very first exposure to making doses that were not normal or adult sized. Okay. So, at that kind of place, I mean, we were making capsules for children. We were doing a lot of IV work. So that was mostly TPN, which is feeding somebody through an IV and so forth and so on, interpreting lab work, things that you wouldn't typically see in a CVS or a Walgreens.
Sure.
So my experience, of course, there was a little unique. I did get into retail for a little while because I needed to. When I first got out of school, I needed a job.
Exactly. Cannot be picky with the first job.
Right. So I did that for a while as part of the Publix chain down here. That's a pretty popular grocery store down here. But I had other skill sets, fortunately. So I went from there to what they call IV home care. So I did that for a while, and then all of a sudden there was an opportunity to start compounding. Now, compounding is the exact opposite of retail. Okay. In retail, you're using, commercial products and you're, dispensing them and so forth, which is a good thing. But for compounding, I was able to take a lot of the chemistry that I had learned and a lot of the analytical stuff that I'd learned, and it all kind of came together. And everyone kind of thinks it's like Eye of Newt and a boiling cauldron kind of thing, but it's more chemistry than you might realize. And it's a lot more sophisticated than just, putting a couple of creams together and mixing it properly.
There's a lot how many more kids would be driven to science type fields if in school we showed them this is what you can do with biology and chemistry, the applied piece of it.
Yeah.
My daughter hated science, hated it. And she had a high school biology teacher who did that. He'd be like, well, this is how it works in real life. This is how it's applied. And
Right.
then she changed and she's now studying like laboratory technology in college because,
Yes.
quote,
Yes.
I like science, not people, is what she told me. But all because of this teacher who showed her what you're telling us about. This isn't just formulas and boring things to memorize. This is where the magic happens.
We have interns here. We have pharmacy interns. And, one of the things that I try to teach them when they come here is to say, well, pharmacy isn't just one dimensional. There's all kinds of things that you can do. And I've done most of them. The only thing that I never really got into was the nuclear side of it. There's nuclear pharmacy as well. But you have to get up at 2 a.m. for the rest of your life if you do that. Yeah, because of the half-lives. So I never really got into that part. Yeah, I wanted a family. So there.
So how long have you been at Infuserve and how did you land there?
I've been at Infuserve for probably 16 or 17 years at this point.
How long has it been around?
Infuserve's been doing business since about 91. Okay, that's about when it was incorporated, plus or minus. A long time. It kind of stemmed from the fact that Lyme disease, writ large, is ignored a lot of the time, and or worse yet, is not considered an actual disease state. It doesn't exist, in other words. And what was happening is that a lot of the patients weren't able to get therapies because it wasn't covered by insurance. We tried this early on and tried to bill insurance companies for our services, and they would simply not pay us. So we had to kind of go to the cash model at that point. And what we were trying to do, and what we still try to do to this day, is, try to make it reasonable. Okay. Now, define reasonable. I mean, like I said, you try not to charge the prices that you would typically charge an insurance company, because those are, as we all know, ridiculous and exorbitant.
Right.
That was part of it. And then learning more about the disease and the disease states that are associated with Lyme, because it's not, everyone knows it's not just Lyme disease, right? It's Lyme disease plus 16 or 17 other different, differential diagnoses. So, we got into the rhythm of doing things like that. It started with all the sterile stuff. Okay, so this was back in the day when they were still utilizing intravenous medications, antibiotics to treat Lyme disease. That fell out of, with the advent of the Lyme Nazis, I call them, which kind of put the kibosh on a lot of that stuff. We still do some of it today, but it was a great learning process for me for the disease state, but it also gave me the ability to put to work some of the stuff that I had learned about intravenous medicine while I was training in Boston, for example, and through all the home care stuff that I did. This involves all of the things having to do with IVs, like PICC lines and ports and the equipment and IV lines and beyond use dating and solutions that you can and cannot put things into. And again, like I said, all the equipment and flushing and things like that, care and maintenance of a PICC line, for example.
It's a big management process. I mean, it's a very big management process.
It is. And finding a practitioner that has any experience in those areas is difficult because they typically don't do a lot of it. And we also had the difficulty of getting, lines placed and nursing, because way back, if you go all the way back, the nursing was actually somewhat paid for. So they were sending nurses for every dose at some point, back in the late 80s, early 90s.
Okay.
Now, they don't do that anymore, of course. It's more like a teach and train. But that's where we kind of came into the educational portion. Practitioners, a lot of the time, call us with those types of difficulties. Okay, so I've got a PICC line. I want to give this person intravenous antibiotics. What do I mix it in? What's the dose? Things like that. That's where we kind of excel. And it's not just me. It's all the pharmacists here have experience in that area. And also all of my technicians have experience in this area. It's not just preparation. It's the fact that you're talking to technicians on the phone. And that's where our practice is a little different than everybody else's. We noticed early on that Lyme disease patients forget things a lot. They have brain fog. So a lot of what we do as far as customer service is centered around that kind of thing. So we make a lot of phone calls. Okay. We're licensed in all 50 states. There's all kinds
Pretty
of different
unique.
reasons for that,
Yeah.
but that's unique in itself. And the fact that we can ship things just about anywhere.
Along those lines with the IVs, I would say, just as a plug for the service you provide, what you say about price, what is fair. There's what we'd like things to cost, and then there's what they cost. But
Right.
I know
Right.
that you guys are fair. And also, I would just let people know you're also paying for outstanding customer service and for people who will sit and talk to you and help your provider make a customized treatment plan, because that piece, I have had other pharmacies. I remember one I called to ask about dose. It was for some IV nutrients, and they said, that's at the prescriber's discretion. I said, I understand that. I'm just asking for a little feedback. But I see it swing two ways. I have pharmacists who don't want to say anything, and then pharmacists who want to say, I'm not going to fill what you said because I don't like it. And you guys are such great the patients. And because, as you said, you're a scientist, what you're telling us is grounded in science. You guys send us articles and research studies, and it's not just a trend. So what we've heard a lot recently, and I spoke to you about it, these studies about piperacillin and Lyme disease, using these microdoses of piperacillin and Lyme disease. And so I'm getting emails from everyone. Oh, I want to do that. I want to do that. So
I mean,
let's
it's
slow
current.
the roll a little, but
you want to
tell
slow
us
that
your
and talk about that?
perspective. Yes.
Yeah. Well, just like anything else, nowadays everyone's got their Google MD. I get that. Nothing wrong with it. I like patients that are informed. It honestly helps my job.
Sure.
But keep in mind the landscape of how that information is conceived and disseminated to everybody has changed so much in the years. I mean, back in the day when I was first, doing this kind of stuff in Boston, I could trust just about every medical journal that I picked up. Nowadays, there's a lot of astroturf out there. And what I mean by that is that it looks like grass, but it's not grass. So you have to look at who wrote it and what their motivations are, because there's a lot of money in changing the narrative. Okay. And sometimes it's even hard for me to disseminate that kind of thing. And I've been doing this for 27 years.
Right.
So I can imagine how hard it might be for a layperson to pull out that information. But that being said, the piperacillin tazobactam thing, there is some basis for this to work. But remember, the article that everybody's referring to is mouse studies.
Right.
There's nothing wrong with mouse studies. Okay. We've been using that type of thing in medicine for time immemorial. But as usual, there's no way. Sometimes it translates to humans and sometimes it doesn't. Just talking about the antibiotic in general, from an infectious disease point of view, it could very well work. Since that came out, we've been putting together a bit of a protocol for that, involving not just the piperacillin tazobactam, but other drugs to supplement this. And again, this is not news. The idea of using monotherapy for a Lyme-related disease went out about 1985. Okay, everyone knows that you're going to have to use multiple modes of treatment in order to get to where you're going. So our idea is that piperacillin tazobactam is something that it's not a limited beyond use date once it's mixed, but it's not terrible. But there are certain limitations for sterile drugs, and it's about 10 days refrigerated-ish. Okay.
And just to clarify for people, this has to be intravenous, right? It's not
yes,
orally
it does.
bioavailable.
Yeah, thank you. Yeah, this has to be intravenous because there is no absorption for piperacillin orally. It's zero. It's not 4%. It's zero. So you got to give it IV. Now, that being said, some people have been asking recently just for piperacillin. Now, that just the piperacillin component went out of print, I think about 15, 20 years ago. So all we're left with is Zosyn. That's one of the brand names for piperacillin tazobactam. So that's what you would have to use. Now, there's two different ways to kind of go about this, okay? One would be the traditional kind of hospital method where you're using a particular dose. In this case, probably for adults, you're probably looking at about 4.5 grams 2 to 3 times a day, okay? Now, if you're going to do this as intermittent antibiotics, they call it, you're going to have to mix the drug, hang it, run it over a certain period of time, flush the line, and then move on, wait the 8 hours or so that you're going to need to wait, and then do the next dose. That's not the only way you can do it, though, okay? There are certain intravenous devices that will do infusions over a longer period of time. And these are generically called elastomerics or home balls, sometimes they're called, okay? And all it is, it's the drug and the diluent. And in this case, about in a ball that's about the size of a grapefruit, more or less. And it's squishy. It's elastic. That's why they call them elastomerics, okay? And they provide pressure. And through the top of this thing comes a piece of tubing. And that's the piece of tubing that runs into your PICC line. And it's the length of the tubing and the diameter of the tubing that achieves the rate at which this is infused. Now, there's different lengths and different, sizes of all of this stuff, but there's one in particular that goes about 10 milliliters an hour, which is fairly small for an infusion. But what you can do is you can take the daily dose of piperacillin tazobactam and put this into this device and have it run over 24 hours. Okay. And then switch it out for another one and keep on doing this on a regular basis. The ball itself is, again, about grapefruit sized. You can fit it into a backpack. You can fit it into a fanny pack. You can do a lot of different things with it. In other words, you're not carrying the IV pole around with you for the duration. Again, it's not the only way to do it, but I like the patients to have options because some options work better for some patients and others don't. That's how we would typically handle the piperacillin tazobactam component. To that, you would want to add other antibiotics and possibly methylene blue. We're going to talk about that later. But the whole idea behind the multiple antibiotics, especially with Lyme-related disease, basically orbits around the fact that you have 3 different forms of Lyme disease, right? You have cell wall, you have intracellular, and then there's this mysterious cyst form of the disease where it's like the storage form. Some people call these persister cells. In the old days, we used to call it the cyst form because it was similar to some of the other descriptions of spirochetes writ large. You're going to have other drugs other than the piperacillin tazobactam. But
that's so critical for people to understand because you see these studies and people desperately want a magic bullet.
Of course.
But it's not one thing that works 100%. I tell people all the time, it might be 10 things that do 10% of what you're doing or 20, it's just all the pieces of the puzzle with eradicating the pathogen, building the immune system, reducing inflammation, just so many nuanced things. So in the context of IV treatment for antibiotics, because I think there's also some misunderstanding about this, who is a patient that you think that would be beneficial for? Because you certainly don't need them, or not everybody needs them to get well, but there are some patients who would benefit from that route. Who would you identify as the ideal IV patient for Borrelia, Bartonella, any of those infections?
Usually, I wouldn't call it a last resort, but you'd want to kind of keep this in your bag of tools. I keep on calling it a bag of tools for you guys. You want to keep this in your bag of tools for people that have basically tried just about everything else and have failed other oral therapies. And that brings I'm going to go to a quick caveat on the oral portion. When the Lyme Nazis first showed up and started giving practitioners a really hard time about this, what happened was that everyone thought if they changed it to oral preparations of the antibiotics that they wouldn't be in as much trouble. Okay. The problem is that with any sort of chronic disease, especially Lyme, and this applies to all kinds of chronic diseases, not just Lyme disease necessarily, is that chronic disease makes you absorb things less well. That's just a thing. It exists. Okay. Right. So the problem is that a lot of these Lyme disease patients are chronically ill, have been for quite some time, 10 years, 20 years, 5 years. Okay. A lot of time. And when you start the oral antibiotics, again, it's an absorption problem. Okay. In a healthy individual, those antibiotics get absorbed very well. And it's not a problem, like when you're treating an ear infection in a child, for example, that doesn't have Lyme disease. Okay. Right. You give them amoxicillin, right, for 10 days and and everything's over. Now, in some Lyme disease patients, they do not absorb things orally very well. So what that means is that you can up the doses, you can shovel oral antibiotics into these patients, but the levels will never get high enough for you to treat the disease. Okay. The other aspect of this is that you need higher levels to treat this disease because it hides. Okay. Right. It goes to places in your body where your body doesn't like to put antibiotics. Okay. A really good example of this is that there's an infectious disease process called osteomyelitis. It's a bone infection. Okay. And you have to use the same kind of thought process to treat that because bone is what they call poorly perfused. Okay. It has a blood supply, but it's not like a blood supply to your lungs or your heart or anywhere else. And your body doesn't put antibiotics there very easily because the blood supply is limited. So you have to have high doses for a long period of time. Well, the same kind of thing applies. It hides. It only responds to antibiotics of a high dose for a long period of time. So if you don't absorb things well orally, then treatment kind of falls off or it comes back or both. So in those instances, you're going to have to, again, open up your toolbox and bring out the IVs. It's not for all patients, but it's handy to have in patients where you've tried everything else and nothing's working.
And I think what you bring up is really key about getting to where the infection is. I frequently tell people, yes, you can say this is great at killing X infection in a petri dish, but if we can't get it to where the infection is hiding, sequestered in your body, can't penetrate those biofilms, it doesn't matter.
Well, thank you for mentioning that because I was headed to biofilms next because that is another key component that is often ignored and is very, very important to getting people well. Is you're gonna have to acknowledge the fact that the biofilms exists, and you're gonna have to get through them in order to get to the organisms that you want to kill off. Now, biofilms, for those people playing at home, we use the term a lot, and some people say, well, what does that actually mean, biofilm? Well, if you've ever tried to, those automatic coffee makers that have the water supply, okay, ever cleaned out one of those things and you put your hand in there, it's kind of slimy.
Right.
Those are biofilms. That's why.
A great description, yeah.
Okay. Those are biofilms, and biofilms are what organisms produce to protect themselves. They kind of slather themselves in this gel, if you will, and the antibiotics only can get through part of it, part of the gel. So they're protected. It's a protective mechanism that is produced by, again, mostly antibiotic-related organisms, but also fungal organisms sometimes produce these kinds of biofilms. So you have to take that into account as you move through the process too, making it even more complicated than it already is sometimes.
Right. Yeah. And that's the other reason why it seems ridiculous if you haven't been in this world long, the number of things a person might be taking at a certain time. But it's because if you're not targeting everything, you're just not going to be effective in your treatment. You also do some unique things outside of the world of IVs as far as compounded medications, bladder installations. You've done some great inhalations for us for people with these persistent respiratory infections. And you'll put in some of those preparations things that break up biofilms, correct? Can you tell us about that?
Yeah, sometimes you'll put in a least for the bladders, especially, you'll use some EDTA. Now, EDTA is basically a chelator of heavy metals. And everyone's going, well, how does that help with biofilms? Well, there is actually some basis for this in the medical literature, okay? And what the EDTA does is it clamps on to different, not just heavy metals, but different cations, I call them, things like magnesium, things like calcium, things like that. And those are part of the biofilms. So the theory is, and nobody really knows exactly how this works, but it does work, is that the EDTA basically kind of puts holes in the biofilm. And by that virtue, that tunnel that it makes, it allows the antibiotic to penetrate further into the biofilm and kill off the organisms. Now, in things like bladder instills, you have to kind of know ahead of time that this is going to be a cycle, because the biofilms themselves are resistant to sometimes our ability to break them up. Okay. And it's like having a whole bunch of different houses with different roofs. And sometimes you can get through them and sometimes you can't. And so what you do is you keep on getting through this. Now, I usually describe it in layman's terms as almost like layers. It's not exactly layers, but it is in 3 dimensions. So you're getting through a certain portion of it and you're killing off the organisms in that layer. And then you have to either do retesting or reassess what you're doing and use different antibiotics to get through the next layer. And you keep on doing that until I get down to what I call bedrock. And in a bladder, that is what's called the GAG layer, the glycophosphate layer that is supposed to protect the inside of your bladder. Once that happens, especially in interstitial cystitis specifically, you can go ahead and utilize different kind of Band-Aids as bladder instills that kind of help that layer heal so that you can eventually get to a point where the patient is much better and hopefully free of the organisms for an extended period of time. Now, yeah, go ahead.
No, I was just going to say, with the bladder installations and the cycles of testing and treatment, I know this is the $1 million question. It varies widely, but if somebody has had these infections for years, they have an IC diagnosis, what time frame do you usually see, like the number of cycles that it can take someone to get to that point of healing?
Yeah, it depends on, I call these entrenched infections for a reason. And in some cases, we have treated people that have had these symptoms for 20 plus years. Right. That's a lot to get through. Okay. Now those will take, the better part of a year sometimes. And again, that's not treatment the entire time. You're Correct. Doing treatment, then you're reassessing what's going on, and then you're treating again. You don't typically do this blindly. And as a really good aside to that, what kind of helped us kind of blow this open and help as many people as we could early on was the utilization of DNA PCR lab work. So we leveraged that. And the short version is that there's nothing wrong with compendial testing, but compendial testing is over 85 years old at this point. And for those of you who don't know, compendial testing is where you grow it on a petri dish and see what grows. Now, the problem with that is that when you do those types of things, the food that you put in the petri dish has to be exactly the food for the organism that you want to grow. Can you see how that might be a problem? And the temperature has to be absolutely right. And then humidity has to be absolutely correct. And so what happens a lot of time is you end up with basically non-culturable organisms. In other words, you get back, oh, nothing's growing. But doc, I have symptoms. No, nothing's growing. Go home.
Or it's a contaminated sample, which clearly means that the woman didn't know how to wipe. That's the other.
Well, there's that too. Yes, and you have to right. And again, you have to have the experience as a practitioner to know what organisms are typical skin flora. Okay, right. And differentiate those results. But the one advantage that the compendial test does have over the DNA PCR is that basically quantification and what antibiotics basically work. specifically for that. They call it a sensitivity. Okay. And all it is that once you've grown it, you put little tiny drops of different antibiotics on the plate to see how much it kills it.
Works.
Or if it kills it at all. Okay. That's called a sensitivity. Now, when you do DNA PCR, there's no real sensitivity. What you get on the lab work is their best guess because it comes from a library. Mm-hmm. But that's where we come in. Okay, when you take a look at these DNA PCR results, you kind of need to take some time to interpret it. Okay, and this involves all the wonderful clinical things that you provide. Okay, when I teach other doctors to do stuff like this, the lab work should be telling you what you already know. You can't just simply say, you can't point at the lab work and say, here, this is it. You have to take into account your interaction with the patient. What were they on before? What are they allergic to? What other things have happened in their clinical history that would lead you towards a certain antibiotic or away from it? Okay. And the lab work doesn't tell you that. As a clinician, you have to use your experience and start making good decisions. And that's, again, where the collaboration tends to come in. Often we will get lab work in conjunction with the practitioner, start making good decisions as to what might work and how to use it. Okay. Because just because it says, antibiotic A or B or C or D, actually utilizing that in the patient is where we come in. Sometimes you can do things like that, and other times there's different things about the antibiotics that prevent you from utilizing it in that particular way.
And also the complexity. I mean, every once in a while you're lucky and someone has a couple of organisms and they're more typical organisms.
Yeah.
But there are some really complex polymicrobial infections that it really does help to have someone walk through resistance patterns, what we should target first, putting that all together with the history, like you've said, the patient's tolerance, hoping they're not allergic to penicillin because that does complicate things.
Right. But and there's a ton of other things to discuss too, because then, especially because of anatomical proximity, a lot of times we end up having to do testing on the vaginal area as well, because there's a lot of back and forth.
Sure.
That's important as well. We've also tested partners, because that's where we thought, I mean, these are all things that you kind of go through. And I'm as far as testing partners, I'm not talking about sexually transmitted diseases. I'm talking about pathogens that are just typically passed back and forth between people that end up being pathogens for this particular patient for any number of reasons. Yeah.
Correct. Also, so let's talk briefly then about what you can do as far as the inhalations. So people who may have these persistent respiratory infections, the unique thing you can do. So I found this out a little story. I was talking to Randy at iLads last year, and I said, hey, my mother-in-law has had this horrible respiratory infection, has been to infectious disease, pulmonology. They'd done a bunch of useless things. I had done some IVs on her and they would work, but then it would always come back despite all the extra things we were doing. And Randy said, hey, we can do this really cool thing for you. And it was great. So tell us about it.
Yeah. And again, we're applying things that aren't necessarily new. These types of inhaled antibiotics have been used in the world of cystic fibrosis for years. And how do I know that? Because when I worked in Children's Hospital in Boston as a young wet behind the ears technician, there was a whole floor of cystic fibrosis patients in that hospital, and they would use inhaled antibiotics. What the game changer for us was, relative to this, was the DNA PCR technology. You could go ahead and really focus in on what organisms were there. And once you knew what those were, then you could start figuring out how to get the antibiotics in more effectively into the patient. You can't nebulize everything. Okay. You can't nebulize amoxicillin, for example. Okay. But there are other antibiotics that are like that you can nebulize. And as a general rule, you're nebulizing things that you can produce sterilely in a sterile environment. And these antibiotics are typically intravenous antibiotics that are repurposed. Now, you can't do it with everything. There's certain things that you can't. And then you have to do some scholarship in order to find out what the doses would be and what the concentrations would be, and dose and frequency, just like everything else, right? But the interesting part is that if you can go ahead and know what you're trying to treat and utilize the antibiotics for that, and then get it essentially to the area where the action's happening, you have a much better chance at getting the patient well. And just so everybody knows, this is not how you start this kind of thing.
No, not
You
at
go
all.
through a whole bunch of other different things, okay? And then when those don't work,
Right.
you are left with this. This is what happens. Now,
I will say though, I compare the lungs and the bladder a lot in that they're just both wet, dark,
sure.
and warm. I mean, they're great places for everything to put its claws in the lining and dig in these layers of infection. And you can test the sputum using the same test that you test the urine with, which is really, really handy. You just keep the same cycle going.
Yep. And to add one extra area, lungs, bladder, and also nasal passages.
True.
Okay. And we've been utilizing this kind of testing in different nasal preparations for 20 years. Okay. I was doing that kind of thing, probably 20 years ago. That's not anything new. But again, you can use the same kind of technology to find out what kind of organisms are there. And in nasal passages, especially in Lyme disease patients, it tends to be fungus or mold. Mm-hmm. Okay. And that's there for any number of different reasons, some of which is immunology, especially in Lyme disease patients. But that's a completely different talk.
Right.
But you can utilize the same types of treatments that you would use for a bladder that you could use in a nasal spray, for example, or something. Sometimes I call a nasoneb. It's like a nebulizer for your nasal passages. It's kind of a bit of a fire hose. It's like an automatic neti pot. It's running these antibiotics and other things through your nasal passages. Again, there's all kinds of different ways to fix that problem too, because you can use different antibiotics and different antifungals in the nasal passages to get people better. Once you have that under control, it's usually helpful for the patient because, especially in Lyme disease patients, the more fungus and stuff they produce in the nasal passages, the more endotoxins they tend to swallow. Okay. And this is a problem for them because their tight junctions in their alimentary tract aren't so tight. And people sometimes call this leaky gut. It does, and this is the funny part. It doesn't mean things are leaking out. It means things are leaking in. The tight junctions are there to kind of modify and keep things from getting into your bloodstream. Well, in people with chronic disease or Lyme disease or any kind like that, those tight junctions are not as tight. And if you have endotoxins that are flowing through that area, sometimes they get through those tight junctions and into your bloodstream. And of course, the endotoxins create inflammation, even more inflammation than they already have. So this is part of the problem.
The nasal tract, it could sound minor to someone who doesn't understand how all of this works, but it can have such profound benefits. And I've had several patients who we've had to be very, very slow with those treatments because of the proximity of this to the brain. There can be a lot of psychiatric die-off. So I've had quite a few people get really stirred up. So we just start with once a day, one squirt, just baby step into it. But
baby steps.
Once you get on the other side of it, it's fantastic. So what are the benefits just scientifically of localized versus systemic treatment? So the bladder instills are a hard sell for some of my patients who we've done these rounds of orals and like, I can't do that to myself. It sounds terrible, but what's the benefit of that from treatment, prognosis, safety, all of those points of view?
Well, the very first benefit, especially with the bladder instills, is that you get to use some pretty exotic antibiotics that you wouldn't normally be able to use. And I'll give you a couple examples. One is the aminoglycosides. These are things like gentamicin, tobramycin, amikacin. Now, when you use these drugs intravenously, you have to do a lot of blood monitoring, because it's what they call a narrow therapeutic index drug, which means if it goes too low, it doesn't do anything. If it goes too high, you can get some relatively serious side effects. Now, when you use these kinds of drugs as a bladder instill, it's topical. Okay. It's not that you can't get a little bit of the drug into your bloodstream. It's just that it's so small, it doesn't produce any of the typical side effects that you would normally see. So you don't need an IV line. You don't need to do monitoring. And the side effect profile is great, honestly, compared to the IV side. And you're able to put the drug in a little bit higher concentration directly to the area that you want it to be in. Okay. So when you're giving, even intravenous drugs to a person with a bladder problem, you're giving it into the person's bloodstream. Then it has to be taken out of that person's bloodstream through the kidneys and then down into the bladder, traveling with the urine once that's pulled out. So you have different effects there. You have the metabolism of the drug, which, could be just in the bloodstream itself or because of first pass metabolism where it goes through the liver and gets changed into a different form of the antibiotic. Okay. Again, like I said, it has more to do with dosing and concentration specifically. And when you do something from the outside, the concentration, even with the dilution of the urine, is much higher in the bladder for these antibiotics. And again, they're really cool antibiotics. And this is the other thing, is that you're wanting to use things that these organisms have never seen before because you've already tried everything else. Okay. I say this to people frequently. It's like, look, if this was going to be solved by, 7 days worth of oral Bactrim, this would be over by now. Right. Okay. So you're in a spot.
Right.
Okay. So now it's time to bring out some of the other things that you would typically use for this.
Well,
And
then
again,
the ability to include EDTA with some of them.
right.
The fact
That's
that
the other part. You're able to put in something into the topical I mean, it is topical. It's like a topical treatment. It's like putting ointment on a cut. You're putting the antibiotic directly in contact with the area that you want to treat. And I wouldn't say it's a better way of utilizing antibiotics that you wouldn't normally get to use. And it's a good thing because a lot of times, and you and I both this from the lab work, is sometimes you'll end up with organisms that are resistant to certain types of antibiotics because they've used them so much in the past orally. You'll see this in the testing. It does give you a little bit of information relative to things that it thinks it's going to be resistant to. It's not like a susceptibility, but it gives you a little bit more guidance as to what antibiotics you should be using.
And do you ever see those resistance patterns reverse? Like on future testing?
Well, here's the thing. I'll start at the beginning of this story. Now, how we started figuring out that there were, I don't know, I'm going to use the word again, different layers of biofilms was this, is that when we first started, we would get the results and we would use a whole bunch of different antibiotics to treat those and they would go away. Okay. But when we retested, we ended up with a completely different set of organisms the second time around. And the question always was, that's great. Well, where were they hiding the first time? They weren't there. Okay. So again, that's a biofilm thing. The other thing about resistance is that sometimes we would run into the same organism the second time around, but the resistance was reversed. All of a sudden now it was susceptible to penicillin, which again meant that there were different levels of the same organism within the confines of the bladder. Okay.
And that doesn't mean it's a bad test. It actually means it's a good test. I've seen
some providers
argue and say, well, that means this is a garbage test.
Right. They think it's garbage, but no. You have to know, again, it's the test should coincide with all the experience that the practitioner already has. Right. It's not,
it's a tool. It's
a tool. It's not a be all end all. You have to use this tool and a whole bunch of other tools because it's so complex.
Right.
You know, it really is. Chronic urinary tract infections are a very complex thing.
And this treatment, if somebody does have to have the bladder installations or they do inhalation, if it's respiratory, in my experience, by and large, insurance is not going to pay for this. They're not going to reimburse it.
No.
But what is the cost to your quality of life of not treating these things? Is one of the things you have to look at as a patient consumer. You are investing in your health. And if you look at all of the chronic symptoms and disability and impaired quality of life and decreased productivity that nag around, if you can actually use effective treatment. I know that Infuserve will help people apply for out-of-network reimbursement. Do you see that come through very often or not?
It depends, not always, but more along the lines of the treatment for chronic urinary tract infection type codes, if you will. You have to code it properly, of course. You know this better than I do. The coding is important. Where things get interesting is that we're back to the piperacillin tazobactam kind of scenario where we're using it for something that everyone thinks doesn't exist, so it's not covered.
Well, and there is a mindset for healing where we all have to come to terms with the facts where if you're counting on the benevolence of your insurance company for your health, you're selling yourself short. So you may be just better off getting a cheaper high deductible plan, because they're all high deductible plans anyways, and planning on using that money to invest in treatments that actually work. Honestly.
The other thing is that once you finally get to a point where you've gotten some treatment and made some gains, you start to realize how bad you were actually feeling.
Exactly.
And a lot of people don't realize this because it's insidious. It absolutely creeps up on you. And that's not anybody's fault. I mean, most of these patients have had this type of thing for, again, extended periods of time. We've had people that have had IC for 20 years.
Right.
So,
healing takes time, but you can feel better.
You can feel better.
Thank you for listening to part 1 of our conversation with Randy Breton. Stay tuned next week. We're going to cover the second part of this conversation where we dig into methylene blue. And remember to have hope, because you were made to be whole. Have a podcast question or suggestion? Text or call us on the podcast info line at 330-439-0686. Thank you for spending time with me today. If you like what you hear, please subscribe to be notified when new episodes release. And remember, you were made to be whole.